Good afternoon, everyone. I see quite a few folks logging on. Welcome to our Coffee and Conversation. We'll probably get started a couple minutes after the hour. Hi, Barry. Are you connected with audio? Can you hear me?
I can hear you. Can you hear me, Kristen?
Yep, sounding good.
Perfect.
I can hear you, Kristen.
Perfect. Thank you. All right, welcome everyone that's joined the line so far. In the spirit of our coffee and conversation, we are moving everyone to unmuted lines. So we just ask you as we open up the call starting at noon, if you're not talking with us, you can put your phone on mute. And then when we have our discussion questions, or if you've got questions along the line, you can feel free to come off mute and chat with us. We'll probably get started a couple minutes after the hour to give folks that may be in clinic a chance to join the call. All right, well, I've got us at 12:01 Montana time. We've got 3 different time zones on the call today. So welcome and good morning to our partners in Hawaii, and then good afternoon to our partners in North Dakota, and hey, everybody in Montana that's in my time zone. So today we are in our 4th session for our Coffee and Conversation, our cross-regional collaborative. As most of you know, but for those of you that are new to CPC Plus, my name is Kristen Schuster. I am the practice facilitator for the Montana region and also the project manager for the CPC Plus program across the Hawaii, North Dakota, and Montana region. And then I would also like to welcome my partner in crime, Barry. Barry, do you want to give a quick introduction?
Thanks, Kristen. My name is Barry Major. I'm the practice facilitator for the Hawaii region of CPC Plus, and it's a pleasure to be here and hear from you guys today. Jeff?
Thanks, Barry. This is Jeff Reddycop, and I am the practice facilitator for the North Dakota region. And I'm sitting here in Minot today. Actually, we have sunshine and 40 degrees, so it's a good day, and it's a pleasure to be here also.
Practically summer out there, Jeff.
For us, it is.
All right, Jeff, you want to take it away for our discussion ABCs?
Absolutely. Thank you, Kristen. So as in past coffee and conversations, we're just going to go through a few ground rules for our session today. And again, the content that we develop for these sessions is for your benefit. So we really encourage you to engage with your peers to be able to get the most out of it. And for this reason, please also try to avoid multitasking during the session. Next slide, please. Our events are really designed to help people in our respective regions be able to cross those regional lines and reach out to others to be able to have some productive discussion and conversation around the topics and the subject matter that we provide. And it's really designed to help you be able to connect with those people that you might not ordinarily connect with. So these sessions are really not role specific in any shape or form. So you'll have a chance to hear from and share with people in a variety of positions across individual practices as well as systems. We'll continue with our quarterly event schedule in 2020. And our next event will be the 14th of February. So you'll have a little bit of time before the next event coming up. Generally, our discussions, our sessions are discussion-based in nature, but we're going to take a little bit of a detour today from our normal format because the information we talk about today is going to be a little bit more didactic in nature, and it's going to give you more of a perspective of the topic that we are going to be discussing. And Barry, I'll pass the ball over to you.
All right, so we have just a little bit of an icebreaker slide, a poll, not really a poll, but you guys can chat in the answer to this question here, which is, what's the most interesting thing you have ever eaten? And I'll just say in recent times for me, I'm a big chocolate fan, and some people had I guess a cacao pod, and I was able to eat the raw seeds out of that, which was a really neat experience. I'd never had it, and it didn't really taste like chocolate either. So somehow they figured out long ago how to make those things from a fruit into a delicious thing called chocolate, but it was pretty interesting. Eager to hear if anybody else has something interesting. They can come off mute, or they can just chat it into the chat window.
I'll go ahead and come off mute and share mine. I would say the most interesting thing I have had, and Barry, you were in Australia not too long ago, so you probably can kind of resonate with this a bit, and you'll have to let me know if your kids like it. But when I was in Australia, Vegemite was something that was probably up there with some of the stranger things that I have eaten. Not a fan. I'm definitely not going to be having Vegemite and jelly sandwiches anytime soon.
You know, my kids were interested in Vegemite until I opened the bottle and showed it to them, and there was nothing happening after that. So I'm with you. I did try it a long time ago when I first went to Australia, and it's tastier than you would think, but it really looks pretty gross. It looks like Jeff had alligator and conch. Sounds pretty exciting. I grew up eating conch in Florida. We have someone else, Christine Kabinga-Bang-Ting-Tang, says chocolate too. Snails and conch and goat. Wow, from Heather. That's a really interesting combination. I'm wondering if that was down in Jamaica or something like that. And we also have frog. Now, is that, Christine, is that the whole frog or just the leg? I've always been confused on that, like which part of the frog. Yes, Heather was Jamaica. Good one. Good guess. Yes, I think it was the goat that tipped me off in the comp. Legs only, Christine says. Okay, I guess that's all you can do in a frog. So it must have been one of those big giant frogs. Wow, good answers. Anybody else before we keep moving on? Oh, scorpion. I kind of have to hear more about that one. This sounds like an episode of something on Food Network, the Strange Eats or whatever it is. Was the scorpion delicious? See if we get a response on that one. It was in China, very delicious after hiking the Great Wall. Well, I've heard hunger makes, it's the best sauce, so maybe you were just really hungry after that walk on the wall. But maybe scorpion is delicious too. That's one I'm not sure I'd try, and I think I'm pretty open-minded. Great. Well, thanks for chiming in on those answers, and feel free to keep them coming. But I think Kristen will move on and get to the topic of the day. How's that sound?
That sounds good. Although maybe I'll have me some scorpion for lunch this afternoon. But today, on a slightly different note, although food is something that is kind of at the center of a lot of health-related social needs when we're looking at how to truly impact patients and population health. So today we're really going to be focusing on building a pathway to population health, specifically with how you can partner with your community and partners across your state to support patients when they are outside the four walls of your organization. So in looking at foundational concepts for what the pathways to population health looks like, this is from the guide, Pathways to Population Health, an invitation to healthcare. And it's identified that these are really the foundational concepts that were created by the Health Research and Education Trust. So to start the conversation, we are going to focus on the left-hand side of this diagram as we look at, what truly creates health. The right side of the diagram that represents the health system, innovative payment models, and the partnerships will be discussed during the second half of the presentation. But really when we're looking at this, the main focus of the discussion will be to share best practices on creating partnerships across the community and state that support the needs of your patient. As you kind of are diving further and further into the world of population health and move past the empanelment, risk stratification, and care management components of population health, you're probably quickly realizing, or if you ask your care team members, they're quickly realizing that all of the needs of the patient population are not going to be found within the primary care setting or the health system in general. It is definitely a key component, and it's one piece of the puzzle, but it definitely requires partnerships as we look at how we can provide comprehensive care for the patient population that is currently in our high-risk pool, but not more importantly, not the word that I want to say, but as we're looking how population health is going to move forward in the future, looking at how you can start to impact patients as you identify, and this is one of the terms that I heard during one of my meetings with St. Peter's, and Amy, I'm shamelessly stealing it because I love it so much, is looking at your patients that have a rising risk and how we can start to impact those patients so they don't get to that very high risk tier, which ultimately leads to a decrease in their overall quality of life and an increase of total cost of care. So the first part of the health and well-being kind of component that we're looking at is where we start at birth. So it begins forming at birth and continues throughout your entire life. Population health is our work that we're doing with our patient population, no matter where they are across that spectrum of aging. So as we're developing through the course of our lives, you can start to look at different areas that may impact a patient early on in their development, later in life. So, for example, a child who experiences toxic levels of stress is likely to have a higher risk of cardiovascular disease and other chronic conditions later in life. Primary care practices are in a very unique position where it's not uncommon, especially in our 3 states, where it's very typical that a patient will have their same primary care provider through multiple stages of their life. I still live in the town that I grew up in, so I still have the same provider. It's interesting how our smaller states and states that are considered quote unquote rural, maybe not so much Honolulu, you do have a little higher population than I think our states kind of combined. But thinking about what the role of the primary care provider will play during each one of these stages of life. Chris from Hawaii, we were talking about this yesterday, about how shocking it can be as a child transitions from what pediatric care looks like into what adult care looks like. Those can be very different. And during that course of the time, there can be a lot of different health-related social needs that go along with that are setting the patient's course of their life into these different areas where you may find them into a higher risk tier later on in life. So this is kind of step 1 as we start to look at health and well-being for our patient population. One of the things that I like from the World Health Organization is the definition of what social determinants of health are. I think it capitalizes each part of it that's critically important. So social determinants of health are the conditions in which people are born, grow, live, work, and age. So if any component of that definition has the ability to impact their health-related social needs. So below is a part of the Dahlgren-Whitehead study. This was done back in the early 90s, and the study, it's quite a lengthy read, but it's very, very interesting. The study attempted to map the relationships between an individual, their environment, and correlating diseases that may go along with it. So you can see in the center are the individuals, our patient population as we look at them. And then surrounding them are the different influences that can impact their health and behavior. The first layer is their personal behavior, so lifestyles, and looking at how this can promote or impact health. So this is where you want to think about the choice of smoking, or are individuals impacted by the friends they have, their community network within their own family, and then looking at the next layer as the social component and community influences and how that plays a different factor on the patient's overall well-being as we look at that. So as we kind of go up and above, we start to whittle it down a little bit more into these different components that you can start to think about playing an impact on the patient's life. So for example, if we go to our food, if there's a food shortage in the patient's life, it could likely impact a multitude of other areas within that patient's community, and also what's happening with the patient's health. So all of these things start to come together. And this is one of the areas when we look at screening for health-related social needs and building that screening within your practice, that you may want to look at this to get an example of maybe what you want to screen for. So for example, I know within my community, water and sanitation is not a concern because we're kind of built on this aquifer system and everything like that. So I don't think that that's something that I would worry about. But maybe if there's something that's in a more populated area and access to water because of homelessness, maybe that's something that you want to consider. So looking at these different pieces when you're looking at how you want to screen your patient population and then ultimately build your network of community resources, this will allow you and your care team members to focus and start to hone in on things that are going to make the biggest impact across your patient population. And so I just want to emphasize that, remember that the aim of true population health is to engage multiple stakeholders across your community that can assist with the multiple influences that a patient may have and need assistance with. So if there is an issue with a patient's access to education, the primary care provider is not going to be the one that's responsible for solving that problem all on their own. But there is likely a community resource that could be a partner that can help the patient or family members get access to the education and build on it from there. So I just want to keep reinforcing that population health is a partnership, because it's very easy to start to feel like you're drowning in health-related social needs because they can be very complicated. A lot of providers are new to creating this relationship with the patient, and they can be very, very time-consuming asks. I know I was looking at helping a friend with a Medicaid application for insurance. It was super confusing. Fortunately, I do healthcare, so I was able to assist. But if I didn't have that information and wasn't a support for my friend, it would not have been possible or as easily possible for them. But I know that there is an educational resource at our community health department that helps patients get signed up for Medicare. So creating that, so you're utilizing the expertise of multiple people and organizations within your community to impact these different components of the health-related social needs kind of landscape. So here are a few examples of health-related social needs that may impact a patient. So looking at the availability of resources to meet daily needs. And this can really encompass a lot of different areas as you're looking at it. Transportation, that can affect the ability to attend school, that can affect the ability to go to work. A lack of income can then influence a whole host of other issues. Then looking at access to education, access to the healthcare services, exposure to crime. This one I felt, I think resonated a lot with me. I don't know if many of you on the line know, but my dad is with the Sheriff's Department, specifically in the detectives unit. And we've talked about the different areas of crime, just because that's part of our family communication, because it's his job. But I didn't think that a child's exposure to crime within their family as a health-related social need. But when I say it out loud, it feels very, very obvious that would be something that could long-term impact that person's life. But just thinking about it opened up a lot of different doors and avenues of, what kind of support would a primary care provider be able to offer a patient that has exposure to crime. And Chris just chatted in, yes, it does. I see it every day with our pediatric population, 100%. I mean, I get goosebumps thinking about it, a child witnessing, whether it be violence in the home, violence around their home, in their community, that leaves a really, really long-lasting impact. And how do we as healthcare providers start to deal and address that? So that may not be something that primary care can tackle by themselves. Obviously, that's a whole host of other things. So looking for resources within your community that may support that pediatric population for this kind of exposure. And then also looking at residential segregation within a community. This one can kind of be a little bit difficult and very sensitive to tackle. Oftentimes the things that are sensitive and difficult to tackle are that way for a reason. So this is something that you would really want to, discuss as a team and as an organization about how this looks. I think of the article around hotspotting that the New Jersey Coalition or the Camden Coalition did about how they did mapping for their patient populations that were their high utilizers within their community. New Jersey is obviously a very, very large area, and it's very, very populated. But based on the admission records, and I'm more than happy to post that article out to Connect. It came out quite a few years ago, and I know it circulated a lot, but there's a lot of really great information in it about this kind of mapping to capitalize the work that you're doing. So long story short, ultimately what they found out was that their highest utilizers were coming from one apartment building within their community. And there was a whole host of health-related social needs for why those patients were in that apartment building, why they were utilizing the healthcare system that they were. And ultimately, they started a population health service that addressed that apartment building as a pilot project that they then expanded out to the fuller community. So Chris, yes, absolutely. I will get you that. I will get you that article. I'll shoot that over to you. It's very interesting. So when you're looking at how you're capitalizing on your care team strengths and starting to focus your resources, looking at these different health-related social needs as it applies to that. And then the last thing I want to mention on this for our system practices that have multiple practices that are spread out across, vast areas of the state. I'm thinking, our billings partners, you've got a lot of practices that are in different areas of the state that may be a little further away from billings proper. And thinking about how different communities within your own organization differ from the practices that may be located in the center of town. So the resources that are provided for our practices that may be in a more residential or more urban area are likely not going to have the same health-related social needs as maybe something that is, say in Red Lodge, Montana, or, on the High Line that tends to be a little more rural, very rural. So think about that when you're looking at population health at an organizational level. Okay, and then healthcare obviously holds a key part of the puzzle to creating health and well-being. And I think we're talking about it. So we're doing the right thing already by looking at how we can address this. But what I want to stress is you certainly can't do this alone. And honestly, it wouldn't be effective if you did. Moving into a sustainability structure within population health is going to rely on close relationships and partnerships with your community and even broader with your state. So in many cases, there are already efforts that are well underway within communities, and you can build off of those partnerships. Everything is relative. I was in Missoula last week, and we met with multiple care teams from the 3 different CPC Plus groups there. And getting together and sitting in the room with one another, there were a lot of eye-opening, aha moments where one organization was doing something that another organization didn't know about, but they wanted to partner with. So if that's just happening within our health system, think about our partners at the food banks, at the rural health clinics or rural hospitals, thinking about our Department of Health, thinking about, my favorite one is like the Boys and Girls Club, if we're looking at work that we can be doing with our pediatric population. So thinking outside of the box of the healthcare system and starting to look at whether they be for-profit or nonprofits across the community, because there's lots of different ones. Barry, Jeff, and I like to try and keep our fingers on the pulse of all of the things that are happening, but there's a lot of moving pieces and there's a lot of people wanting to do this work. Woo. Can you mute your line? If you're not talking, I think we got it. Mute your line. Ooh, man, that noise. That's brutal. I forget to do that pretty frequently though, so I think I'm just getting some karmic feedback coming back my way. But as I was saying, so you're thinking about where we want to go in population health. The early stages of CPC Plus were really you exploring and getting your feet under you for what this kind of healthcare transformation and what the payment changes looks like. Now, as we're moving into the 4th year of the program, we can start to tackle some of these more complicated problems and start to get outside, again, of the 4 walls of our organization as we start to figure out how to take care of our most sick patients, and then, very importantly, thinking about how we can keep our patients from getting into that seriously ill patient category. So thank you for letting me, again, can you mute your line? Or computer. I think that's maybe the feedback of your computer if you're a calling user and you're using it on the computer too. So with that, we're going to move into the discussion portion of our presentation today. So I'm going to go ahead and turn it over to, oh, actually I'm a slide ahead. Sorry about that. So before we get into discussion, sorry, the noise threw me off in my order of operations in my brain. Still only human, even though I sound like a prompted news anchor when I try to present like this. But looking at where you start, so simple, right? My favorite thing I always say to all of you when we're coaching is like baby steps to greatness. So let's not try and tackle full on, homelessness or food inequality and all of that in one fell swoop. Let's start small and then expand based on what's working. So begin to explore opportunities in your community based on what you know about your community. You know what the health-related social needs are within your community. You live there, you work there, you play there. All of those things, you have that knowledge, and so does your staff and your team. So talk with people within your organization to feel out what the deficiencies are, and then start looking at networking with other organizations to get better understanding of what work they are doing and how that can, fit in with the work that you're doing. Nobody wants to do double duty. Everyone wants to do the right thing and capitalize on these partnerships to lessen the weight and the load for everyone involved. So after you look at networking, you all know me, I love coffee. And so, go have coffee with someone that's part of an organization that you think could be a potential partner, and just listen to the work that they've been doing and understand the history within their organization of what they've been working on. Then you can identify those potential partnerships. Then after that, this is going to be one of my other big buzzwords that you guys are going to hear me talk about a lot, is create a common core language for your stakeholders and your partners that are involved. In healthcare, we have a very specific language that we speak. We go down a layer within CPC Plus. We have a very specific language that we speak, whether it be integrated behavioral health or behavioral health integration. Do they mean the same thing? Sometimes yes, sometimes no. But creating a common core language, so no matter who your stakeholder is or your partner, they understand what goals you are trying to accomplish, and you're speaking the same language. So you then understand what they are trying to accomplish as well. So then you can capitalize on that to make sure that you are both making change that benefits each other. And then maintain open communication with the partners. So, you may go through phases where you are calling the food bank all the time, or you're working with them a lot because you have a lot of patients that all of a sudden hit the radar of that's what you're working on. But then maybe there's a lull. Keeping that communication open so they are aware of what's going on from your perspective and what's going on for them will make that relationship very symbiotic, so you can go back and forth with one another on a continual basis. And so they always know, like healthcare is always doing, they can always know and understand the changes that are happening to then build off of that common core language that you've already created. Okay, so with that I think I am done with my presentation, and we can get into the actual kind of discussion questions to hear more about what you all are experiencing in the field for how you're building these different community partnerships, or how you would like to do that in the future. So I think I'm handing it over to Barry to read our discussion questions and kick us off. Barry?
Thanks, Kristen. That was a great introduction. And thanks for setting like a really good foundation on sort of the task and the approach to, health-related social needs and building community partnerships. So we'd like to change now from sort of presentation mode to more interaction. We want to hear from, as many of the practices on the line as are willing to share about their approaches to this issue. And specifically, we'd like to start off with how is your practice engaging community partners to expand and build upon the work of your care team? Let's hear how you began engaging community partners, and it's a really good time to come off mute and tell your practice story. If you prefer, you can do it in the chat box, and we'll try to narrate what we see in the chat. But let's get some input from the practices on the line, and I'm gonna just pause and be quiet there for a minute and see if we get some comments off mute or in the chat box. So I'm seeing a comment from Christine. Thank you, Christine. So it sounds like you have you've connected with partnerships with Times Pharmacy. So for folks who don't know, Times is a sort of chain of grocery stores, sort of grocery and drug stores in Hawaii. And so looks like she's working with practices that have partnered with Times for comprehensive medication management, and then diabetes programs. And then they've also looked at partnering with the YMCA for pediatric weight management and DPP programs, and they're starting next year. So that's really good. Christine, I'm wondering if you might elaborate a little bit on sort of how many, is this multiple practices that are doing this, or just one in particular, or does it depend on the type of program? Okay, so Christine said our MSMP, so that is a particular physician organization of several, I think it's 6, correct me if I'm wrong, 6 CPC plus practices, possibly among others, that are all sort of collaborating. They're solo practitioners, but they're collaborating on sort of their approaches to sort of raising the bar and meeting a lot of these more complex CPC plus requirements, things like CMM and behavioral health and such. Really good, thank you for that. Input, Christine. Interesting to hear about using, local pharmacies that already have pharmacists embedded, and using the YMCA and those sort of community resources. Oh, and then you've added the Filipino provider. So it sounds like maybe the sort of a practice maybe up in Waipahu. Great. So then I see a comment now from Kathy Foltz. Developing a relationship with the tribal community health services and other care coordinators at other healthcare facilities. Very interesting. So I'm curious about that. Does the tribal community health services have sort of an interesting, like a wide breadth of offerings, or are they sort of deep in one particular area?
While Kathy's typing out, I want to say how much I like that looking at other care coordinators at other health facilities. Yeah, absolutely. Probably also if like your health clinics are kind of right down the road from each other, or your hospitals are right down the street from each other, you probably share a lot more patients than you would think. So creating those relationships across other health organizations is another way to just keep building that group of community partners. Hey, Jeff, any fun partnerships that you've seen in North Dakota?
Yeah, I can speak to one that I can think of right offhand. We've got one practice that's in more of a western part of the state who's developed a collaborative partnership with an individual practice that provides behavioral health services, because in that particular area, substance abuse is pretty high. And I'm actually pretty familiar with that area because I drive through that area every time I go home to visit my parents in Montana. So that's one partnership that I can think of right offhand. And here's Tom on the opposite end of North Dakota and the eastern side, shared that a couple of practices are doing group visits at an exercise facility, recurring meeting with other local health systems, college public health to discuss preventative health, providing patients with vouchers for taxis and hotels, a community paramedic that can provide home visits for patients, and also do some work with parish nurses and food shelters. So it really sounds, Tom, like your system has got a wide web developed. Would I be able to ask you to come off mute and talk just a little bit more about the community paramedic services? Because I know that's something that we talked about at one of our site visits not too long ago.
Yeah, are you able to hear me?
Yep, we can hear you.
Okay, perfect. Yeah, so the community paramedic is a newer resource that our health system has partnered with, and I think our health system actually owns this community paramedic, so they do work for our health system, but they do, primary care providers can put in referrals for them. They can do home visits and do a lot of things regarding going into the home, doing assessments in the home, doing med reconciliation, doing some high-level things like checking blood pressures and things like that. So really it's for the patients that the providers want that a little bit more, a little bit better of a touch point rather than having them come into the clinic. So they've seen a lot of value with actually going into the homes and meeting with patients there.
Thanks for sharing that, Tom. That's really a great extension that's been able to be provided with also without putting extra strain on the staffing levels of your respective clinics. And Sarah over in Grand Forks had mentioned that her organization meets with many partners in the community to share services and ideas, public health nursing services, behavioral health agencies, and then YMCA for their DPP, etc. So can you tell me a little bit more about some of the areas where you're partnering with your behavioral health agencies on? And if you want to chat in, Sarah, go ahead, or if you want to come off mute, please go ahead.
While Sarah's typing, Kathy chatted in back to Barry about the tribal health services in the community there. She said, so it's for the residents that live on the reservation. They help find services that our tribal patients have available to them. That's a kind of a unique relationship that happens between primary care, especially for those communities that are either your primary care practice is on the reservation or it's very close. It's likely that you'll share patients across. And there are a lot of resources that are available to the tribal health and the reservation patients. So that's a fantastic partnership. I know we've partnered with a group on the Blackfoot Reservation about doing diabetic and group classes. It was kind of outside of CPC Plus, but it was a very logical kind of partnership to, kind of launch into that and utilize that community space at the reservation level. So just wanted to share, I think that's a fantastic idea.
And I could follow up on Sarah's question I posed to her. She just mentioned that they refer patients to some of behavioral health agencies that provide longer-term services, such as medication management and counseling. So it sounds like there's a definite focus on trying to extend that time frame for those patients that need that extension, and just not focusing on just immediate one-offs. So thank you for sharing that, Sarah.
And I have just a follow-up question. So there's a lot of organizations that have kind of been name dropped on in the chat and through what Tom shared. And just a general question, were these community partners pretty open to working with all of you and kind of doing this extension of the work? It may seem like a logical question, but as we're working on the beginning phases, were they open to collaborating? Simple yes or no. You can go ahead and chat that in or come off of mute.
And Kristen, while you're waiting for those responses, this is Barry. One of the ones I hear a lot out in Hawaii from practices is Catholic Charities. I guess they're pretty well established, well connected locally. They help with food, transportation, housing, et cetera. So that's another one of the ones we've heard quite a bit.
Hi, this is Sarah Elliott from St. Peter's Health in Helena, and I would say that our community partners are very open to collaborating. It's something that they've wished that we would have been able to do, years ago, but we just didn't have the capacity before CPC Plus. And so, we've kind of gone into partnerships with community agencies and owned it and said, hey, we're sorry we haven't been, a good partner to you, but we're here now and we want to know, how can we work together to really improve the health of our community.
I love that. That's like simple relationship building, 101, recognizing and addressing and being transparent that, maybe the relationships weren't as strong, but hey, moving forward, we want to go ahead and we want to do this. And Sarah, I love that you mentioned the payment component, because in our foundational concepts to health, the kind of part 5 of how we can engage health partners is create innovative financial models. I see that DPP was mentioned a couple of times, and there's some fantastic billing opportunities for that I didn't even know about that are great for our Medicare patients and for some of our commercial partners for better managing diabetes. So there are people that have the expertise in that, and they can also bill for those services. So that adds, another layer of support that the patient can have, and also is a sustainable approach as well. Kathy chatted in, we all see the huge benefit for our people. I love that.
And I'll circle back to North Dakota, and I see Tom and Sarah both chatted in that basically in our state, their experience has been that the community partners have been very willing to collaborate. And I like your comment about, Sarah, about community events surrounding things like poverty that have helped form relationships. Here's one question I'm just thinking of. How often have you been involved in some type of a volunteer activity that's eventually led to a partnership with another organization with the community? Just kind of something to think about on the side.
Hi, this is Sarah Elliott again, and I think our new administration that we've had at St. Peter's for maybe the last 2-3 years. They've been very encouraging of us to like volunteer in the community and serve on boards or coalitions, and so I think just getting ourselves out there has really helped drive partnerships, because we're not just like this isolated entity that's, you know, only caring about our bottom line. I think organizations see that we're willing to collaborate and partner with them.
That's great. Thank you for sharing, Sarah. That's fantastic. And thanks everyone that chatted in. All right, we are going to go ahead and move to the next slide and keep our discussion going. Looks like we've got about 15 or I guess 12 minutes or so left. So looking more into the future. Oh, go ahead.
Oh, so just to build on what we talked about so far, and as Kristen just mentioned, looking towards the future, what are some of the areas of patient care that you'd like to work more closely with other community partners on? What are some specific areas?
As I mentioned earlier, my personal goal that I want to explore more is the support for pediatric patients that have been exposed to crime, and seeing if there's any resources at the local law enforcement level that they may be able to point me into a direction that may support our patients in the community around that. So that's my personal goal. So I'll keep everybody informed of what I find out across our Montana communities.
I think that's definitely a great goal. Nikhil, I saw you on the line, so would you mind chatting in? I can call on you, mind chatting in or coming off mute and sharing what some areas of patient care that Mid-Dakota's like looking at working more closely with other community partners on.
Sure. So with Mid-Dakota, we have quite an older population, and so we try to work with, you know, like adult abuse organizations and things like that. I think our limiting factor always becomes like we have one social worker, and so trying to get all those patients in contact with these other organizations is always the struggle for us. Trying to get them all those proper resources.
And do you have steps that he takes to be able to prioritize?
Yeah, and he also keeps together a list of our various community partners and who to refer to for various things or who to contact. And so a lot of our nursing staff has that list too. And so sometimes they'll just reach out on their own, but the more extreme cases go towards him to kind of do the more follow through and follow up.
Sounds like he's your point man.
Yes.
That's great. Thanks for sharing. And Kathy, yeah, I totally agree with you. Suicide prevention in younger population. I myself grew up on the reservation in Montana, and I saw that firsthand. And I think, you know, in those, particularly in those types of communities, along with just our states of Montana and North Dakota, the ruralness and these long cold winters that we have, they really tend to drive up the prevalence of mental health issues. So yeah, Tom, I totally agree with you too there. Big topic for Sanford right now. Okay, focusing on pediatric population.
And Jeff, we also heard that from Christine out in Hawaii, the sort of focusing on pediatric behavioral health, things like bullying and obesity. So it's interesting to see across these regions the sort of the emphasis on pediatric issues.
Yeah, bullying is definitely a major issue nationwide. Thanks for sharing that, Christine.
I think we may be seeing a trend for maybe our some upcoming coffee and conversations. It looks like quite a few organizations are going down the road of the pediatric world, and maybe this is a good opportunity to reach out across the states with our partners and see if we can again kind of divide up the work that needs to be done and share those best practices. Again, to keep our pediatric patients healthy, kind of early on in those early stages of and very formidable years as they kind of transition from pediatrics to adulthood.
Hi, Sarah Elliott again. Regarding like the suicide in the pediatric population, I'd be curious to hear if it is a topic, for an upcoming coffee and conversation, but how folks are kind of partnering with their schools to prevent suicide in young adults, because we found, the schools kind of have their own things that they're working on and doing, and just maybe seeing that like in a more global community lens, so it doesn't feel like we're double doing, I guess.
I really like that. I think that's like a logical, partnership to kind of reach out and explore. I mean, if we've got behavioral health that's going on in the school, that again is kind of creating that common core language to figure out, what are they working on versus what are we working on, so it can then align, so it's not so overwhelming for both the children and then also for the parents that are involved as well.
And one logical partner for some communities could be just partnering with the local churches on this issue. Not only suicide prevention, but just general mental health problems in our young people. I myself work with a group of young people, junior high age, at the church that I attend, and every year we bring in a community mental health professional to talk to not only the kids, but talk to their parents as well about suicide prevention, mental health issues, and how to be able to deal with those. And I think being able to, for the practices, particularly in my home community, being able to partner with those churches could really produce a lot of value. And Christine, I like what you said about vaping too. Vaping is just becoming more and more of a nationwide issue as well. Wow, children as young as 8 years old. That's just sad. That's just sad.
I do like what Chris said though about off that building off that topic is partnering with the Department of Education. Didn't even think about that. I work with the Department of Health in Montana and Hawaii. Why wouldn't I approach the Department of Education and see what they're working on? So that's a fantastic idea that gives me an action item too. So I think we're kind of running out of time here. This is awesome. So I'm going to pop over to the next slide and we'll keep these discussion questions maybe a little concise. Barry, go ahead.
I think in just the last few minutes we have, we'll just see if anyone has any sort of comments or advice on how to, how to really make these discussions and these engagements with community partners really productive. Is there any sort of tactics you've had to, like the last bullet says, to really maximize your time and ensure productive engagement? Just any sort of short tips on process and approach that might help other folks that maybe are feeling a little less far along in the curve.
I like how you phrase that, Barry. I think it's so easy for us to get into the mindset of, oh my gosh, it's one more meeting. Oh my gosh, it's one more coalition. So, having a clear plan may be the best way to maximize time. Well, maybe that's something that we can kind of think about for future. If anything comes to mind, maybe it's something that you could post out to CVC Plus Connect, to the regional pages, if you've got any best practices.
And Kristen, just real quick, I'll interrupt you real quick there. Christine from Hawaii did sort of say they tried to present their focal points and inform the potential partners of what they were looking for in a partnership. So thanks for that, Christine. I would imagine, giving them context and sort of explaining, what particular things you're focusing on and how you can use them would be helpful. But sorry about that, Kristen. I'm going to let you go because I know you have to wrap up. We only have about 3 minutes.
Yeah, no worries. That's no worries. I'll never be heartbroken that we interrupt to keep this great conversation going. This is fantastic. All right. So with that, we can pass it over to Jeff for some leaving in action and a couple house cleaning items. Oh, maybe we lost him. All right, so our typical leaving in action.
I was on mute.
Oh, yeah.
Sorry about that. Yeah, sorry. So think about one key item that you heard about today that you're going to take back and share with your practice team. And think about the participants that are on the call today. Who do you want to reach out and have a little bit more discussion and share resources with? And then again, just think about another topic that you'd like to talk more on for our upcoming conversation in February. Next slide, please. Here are just a few choices. If you have some other ones that you're interested in, please go ahead and feel free to chat those in, or you can email any of the three of us with a topic that you're interested in, and we can start to begin to develop some contact around that topic. In the interest of time, we're going to go ahead and advance real quick here. So as mentioned earlier, our next Coffee and Conversation session is going to be in February, actually on Valentine's Day. So we're looking forward to that. There'll be a little bit of a time gap to give you all some adequate space for your year-end reporting that you've got coming up. And we're going to be looking forward to getting together with all of you again at the first of the year next year. As always, keep the conversation going on Connect. Feel free to post your questions, summarize some discussions we had today, and share tools and resources and helpful hints. Next slide, please. And here are just a few extra resources from our presentation today that you can find at the accompanying websites. So please definitely go do and dig into those. Next slide, please. And remember that the post-event survey is coming up after we close out here. This is a really valuable information for us because it helps us develop further content. It also helps us evaluate how you think these events are flowing and can help us be able to make positive changes so they bring more value to you. So again, please do definitely fill that out. And yes, the next Coffee and Conversation is February 13th. Sorry about that. Was one day ahead there. If you have any additional questions at all, please do feel free to reach out to any of us at any time. We are here to serve you all and help you continue to move forward in your practice transformation efforts. So with that, I'll turn it back over to Kristen and Barry for any final thoughts.
Nope. Again, I'll plug the post-event survey. We'll go ahead and we'll email that to all of you, so it'll be hitting your inbox very shortly. We look forward to a great conversation in February. Thank you all very much. Have a very happy and safe holiday season, and we will talk with you all very soon. Thank you so much.
Thank you. Bye-bye.
Thanks, everybody.
Bye, everyone.
Bye.